Okay, so thanks for coming. For those of you that don't know me by now, I'm Mike Crosby. I was first diagnosed with prostate cancer in 2015. I think at one point, my friends at one of the big companies told me I held a record. Early on, I had about 5 PSMA precision images. And the key out of that whole lesson or that experience is that I want to say that, and my physicians, oncologists, and radiation oncologists, and everybody will tell you that my treatment changed every time there was an image, because it found new things each time that we had this image done. And so the course of my care, as I tell people, I wouldn't be here had it not been for nuclear medicine, hence why I'm a little bit passionate about this technology. So with that, we would like to first thank all of our sponsors, Eli Lilly, Blue Earth Diagnostics, Curium, Mirion Medical, Eisai, ITM, Lantheus, Novartis, and Telix, for your generous support. Without you, we would not be having this event, and we wouldn't be educating these patients that are out there. So we got 2 incredible speakers that have been leaders in this industry. First, to my left here is my friend, but also highly respected physician, Dr. Frankis Almaguel. He's a nuclear oncologist who serves as the director of the Molecular Imaging and Therapeutics Program at Loma Linda University in Loma Linda, California. He's currently the chair of SNMMI's Prostate Cancer Outreach Working Group. So if you have physicians or offices or clinics that want to hear details about precision imaging and nuclear medicine, we have an outreach working group, which I am privileged enough or honored to be on as well, but we are always looking for opportunities to come and speak at a very technical level about what is nuclear medicine and how it can be applied in a clinical setting. So contact us if you have any, or you hear of anybody that wants that. And I think you'll hear through these next few minutes a little bit about Dr. Almaguel's passion and how this works and why we're doing all this. So first is, I'm going to ask him to answer this question: what is nuclear medicine, and how is it different from other imaging or treatment options that all of you may be familiar with?
Well, nuclear medicine is unique. Before it was used to be called unclear medicine, but now with the new scans and new advances in technology, we're becoming pretty clear. And imagine that we're looking at the functional aspect of cancer instead of looking at structures like when you do a bone scan or a CT scan or an MRI. Structures, now you're looking at moving parts, how the metabolism works inside the cell, so you can tell a lot more, right? It's not the same to show just a brick structure than when you can look inside what's happening inside that bridge. So we can make decisions like my friend Mike was saying. Imagine he was privileged to be doing this even before the approval of PSMA imaging. So I was going to mention later on that, yes, the advantage that we have today is that we have the problem of having advanced imaging to let doctors make better decisions. Sometimes that means more work for doctors and more thinking, but this is actually better for patients. And I tell all my patients, you have to be an advocate, and you need to learn about your disease. You have to be, not only for you, but for your fellow patients that are going to come and ask you. You need to be an advocate. You need to talk to your doctor. You need to be involved. You need to make a decision together with your doctor. You cannot let your doctor just say, this is what you do. But this is not the question now. So nuclear medicine is a precise field where we are able to give you more information and about the functional component of an imaging.
Great, thank you. So next is molecular imaging in precision oncology. It's biomarker imaging, really, which is going to allow us to see things down at a molecular level.
That was the answer of the question.
Right.
I had it in a picture. So if I show you the CT scan portion of that patient, you will not see anything. But you can see, you don't need to be a radiologist or a medical specialist to see that. And let me ask you this question. Do you see where the cancer is?
Here.
Anybody? Tell me where the cancer, you see the cancer cells, the cancer metastasis. Okay, Mike, press the button.
I did.
Now with the PSMA PET-CT, you can see what they are. This is better for patients because it's better for physicians because it gives you more information about what to do next. And this actually was a patient that was scheduled for surgery. And we found that. If we had done surgery, we had given him all the side effects of surgery and no real benefit. We could close the talk right now saying precise imaging allows us to treat patients better. And Dr. Sartor and I are here because we took a note to help our patients, and this is definitely helping us help you, and I'm telling you, it's a great feeling where you're informed, where you can make the right decision for the right patient at the right time with the right tools. Well,
So here's the technical side of the world here. So there's a little bit of a technical deal, but this is down at the molecular level and what you're really looking at. So explain, if you would, how this really works and why it's really working.
So as you know, Mike is a very smart person. He served in many leadership components in this planet, but I gave him a lot of freedom. I gave him some slides and he chose them for me. And sometimes, I'm telling you, this is a very good slide. This is the reason why nuclear medicine is great at looking at function, because we are a biomarker-based imaging and therapy scenario, right? So if your prostate cancer cells has 1,000 times more PSMA than your, toe cells in your toe, then when you image, you're gonna see the prostate cancer cells. You're not gonna see any other cells. And I'm very general because I don't want to go into details because of the specificity of PSMA, but it's overexpressed in prostate cancer and is expressed very little in others. Now, imagine if you want to send a micronuclear bomb to the cancer cell. You want to make sure that the collateral damage is little. So that's why we want biomarkers like this. Okay? Mike, I'll follow your lead.
No, it's good. So how is it determined that a patient should actually have this done? Or who determines that? Where does it come up in discussion? What should a patient say, or what should a smart patient say to a physician about this during his visit?
I mean, Mike doesn't know this, but this is a very loaded question. So there are like multiple guidelines and hundreds of hours between very smart people deciding when should we do a test, right? When should we do this? But I can tell you this, and we're going to make this question relevant for you. If you have been diagnosed with prostate, and let's forget about all other cancers, and let's be very, very, very selfish. Let's forget about everything else, just prostate cancer. If you have been diagnosed with prostate cancer, and your PSA is changing, so if you're initially diagnosed and they have done a biopsy and your risk is higher than, a Gleason 6 or a Gleason, you say, hey, maybe talk to your physician about this test, because the decision between doing surgery, radiation, or other therapies hangs in the balance of with the right diagnosis. And as Mike mentioned before, a PSMA PET-CT changed the way his case was managed. And just like it changed the treatment scenario for the patient that you just saw the picture with the little bullet in the prostate, right? Yes, you have to be part of, if you don't know anything about PSMA, you should, if you're here today, you have a problem because of having access to more information. You need to know what a PSMA PET-CT is, and you need to know how that could affect your disease. So the idea is PSMA imaging is changing the way we manage prostate cancer.
And so what's coming down the line? What should people be hopeful for? Or this kind of is going to lead, we're kind of going to merge into the trials issues that Dr. Sartor is going to speak about. But I mean, what's happening in the field right now? I mean, this is evolving. Someone said yesterday that we are facing a tsunami of information or a tsunami of data that's going to come out with all of these trials and all the research and development that's going on in nuclear medicine. And you're an expert in a lot of them, right? I mean, you're doing a lot of, just doing 1 or 2 trials, I know right now, right?
Several.
Yeah, 22 trials he's involved in right now.
But I can tell you this, with knowledge comes much responsibility, right? Now that we know how PSMA has not only revolutionized the ways we image, right? And the way we make a diagnosis. Now that we know that it's also very important in a therapeutic intervention, right? We have our PSMA-related therapy treatments, which you're gonna hear more about that soon, but it's actually helping our patients live more meaningful lives with less side effects and with a increase in survival. So when you put all that together, you have to answer a question when somebody tells you, hey, what about if I don't have prostate cancer? And this is not only confined within prostate cancer when we're using more and more isotopes to do the same thing, hopefully better, but this is also spilling away from basically all other cancers. And we don't have time to talk about that, but I can tell you, this works, and we just need to find a way of making it work better.
So there's a concern from everybody in the room's perspective about radiation safety. And, you know, am I going to glow in the dark? I mean, I know I have an incredible personality, but, you know, is this making me glow, or, you know, is it just our friendship?
I think it's a combination. No. So I was I remember like today, I was in a room treating one of my most quiet patients. There was this little mice, and I was injecting the tail vein of those mice. I don't know if anybody had done it, but it's complicated. And I was injecting them with a radioactive arsenic. As you know, arsenic is bad, it kills you, right? But in the amount that I needed for doing imaging, these mice were just fine, because this tracer principle in nuclear medicine is I can give you a tiny, and he's actually trying to show you a grain of sand in the hand over there, right? That little touch.
It's not on there.
It's not on there, but basically, I can give you a really tiny little thing that is not going to affect your physiology. So you could be a diabetic, and I am doing a FDG PET-CT. It's not going to increase your blood sugars, right? So the bottom line is it works in a soft-physiological level, and the radioactive safety, in the radiation safety components, this is a really, really safe, and when you look at risk and benefits, the risk of having a scan is nothing compared to the benefit that it can give to you. But even when we say that, we are very careful selecting who gets the scan. We're not going to just do a scan just because Mike shows in the door, hey, we get a scan. And we do it before. If you do the imaging for the right reason, there should be no concerns with other side effects of this imaging. It's a very safe procedure, and it can have great opportunities to change the outcome of your disease.
So I have a question for you. Why is it when I go in and have my scan that they put you in a lead-lined room and you have these, you know, big rubber gloves that everybody's wearing, and they shut the doors, and, you know, just to bring this little vial, it's only about this big, bring this little vial in there and then inject it into your body? Why are we protecting this thing like it's like what we just bombed in Iran, right? I mean, it's like, you're living in this lead-lined room and getting an injection in your arm, but it's, you know, the lead's what, 3-4 feet thick, and it's like, it's crazy. So why, then you tell me that it's not scary or it's not gonna hurt you. So why do we have these big rooms that we're doing this in?
Well, we have a commitment with society, with our patients, and with the world. Because since we cannot see radiation, we have a commitment to have as low as reasonably achievable. So we're gonna try to minimize the radiation that can be affecting anybody else but the patient. We have worked really hard to make that into a reality. However, we have regulations. We have a thank you, sir. So the bottom line is, yes, we have protocols and we have these procedures to follow, but it's just because we want to make sure that we are very clear that we are doing everything we can to limit radiation to where radiation shouldn't be going to, right?
So are these big walls really for, like, if you spill the stuff on the floor? I mean,
No, not really. Actually, we have procedures after you're gone home that we check that there is no spills, there is no radiation just lying there, all this. Like, remember,
so don't be scared of the big lead-lined walls and stuff like that.
remember, you have CTs, PET CTs, and you have machines, and it's a complex environment. What I need to tell you is you have to be not only thinking about your patient, about your employees, about the visitors, about you. It's basically, since you cannot see the radiation, you want to be sure that if somebody asks you for your policies and procedures, that they can show, hey, we have done everything we can to tell you that we have done all by the book. And that sometimes that book means that you have to have those regulations from everyone, from all the societies, right?
Okay, so we ask, when a patient first hears about this, what are questions that you typically get or that you try to encourage patients to ask and to understand in that first visit when they first hear about that they're gonna get a PSMA PET or you're looking at a nuclear medicine precision image or something like that? What are questions that patients really should think about asking the physician?
So patients come to, first they're diagnosed, and this usually happens very early when the primary doctor will see that the PSA has changed. That triggers a reaction where he goes to a specialist and more tests are performed. And then there's some things that will trigger a PSMA PET CT. And very few patients have the opportunity of sitting with their physician to discuss the PET CT, right? Results and look at the pictures. So when you first come to the center where I am going to be performing the PET CT, your referring physician have already told you a little bit about this imaging, I hope, right? And I also encourage my fellows and my patient interacting personnel to ask the patient, hey, if you have any question, I would like to talk to you. I would like to give you an opportunity to know what you're getting into. But basically, it's just going to be injection. We wait for some time to circulate, and then we'll sit you in a machine where you send the energy to translate that radiation to pictures, and then hopefully those pictures will change the way we treat you.
Yeah, for you guys that haven't had one before, I can tell you from experience, you literally show up and you can't be late. The reason you can't be late is they set a time, and all of this nuclear medicine has a half-life, right? I mean, we're talking hours from the time it's manufactured to the time it has to be inside your vein, okay? So if you get stuck in traffic, if you get stuck somewhere, it's gonna be a problem, and you're gonna have to come back and do it again, right? So it's imperative that you get there a little bit early, and believe me, it's worth the wait. So and what happens is they give you an injection, you check in like anything else, they take you in the room, you get an injection, and then you wait. You've gotta go wait for your body to process it, right? It goes up through, what's it, about an hour, I think now, 40 minutes to an hour? And then, at that point, they call you back and you lay on go take a 20-minute nap on the PET CT machine. And what's brilliant about that is when you're finished, the results are right there. That's what I think is neat. I mean, I guess probably because I'm a little bit mouthy and I know Dr. Barangi pretty well. He would take me right into his room and show me exactly what was on the screen, right? And so they're trying now to standardize or to optimize the image reports that people can get as a patient, because you don't, there's a lot of technical stuff in those reports, right?
Absolutely.
And we also try to promote that not everybody is trained to read those reports, okay? So not every physician knows what they're looking at. So you gotta sometimes ask or challenge the guys to make sure that they're qualified to be able to read those reports. Or if you have a question, as we always say, go get a second opinion. Take your report and go get a second opinion, okay? And anybody that has a problem, I mean, I love you to death, but, I may ask a second opinion of Dr. Sartor, and it's one of those things that doctors shouldn't care. If they care, then you're seeing the wrong doctor.
Actually, this is very critical. I believe in my patients becoming experts here, right? So I send my patients to top physicians in America. Say, hey, you go ask him. I mean, I'll be available for you when you're talking to that physician. Just put me on the phone, because I want you to hear it from multiple directions. Because when the patients come to me and they tell me, my urologist told me I needed to do surgery. My radiation oncologist told me I needed to do radiation. And the other doctor was not sure. I am not sure. What should I do? I say, wait, I cannot tell you what to do. I can guide you, and we can make a decision together, because patients that feel comfortable working with their doctors and making a decision together with their doctors, they don't only feel way better about what they have done. There is data that shows that these patients live longer, and I cannot take away that from you. And hopefully they don't, I have some patients that have been fired by their doctors because they asked too many questions. And they want to know about that clinical trial, about these other things. And they'll say, if you're coming to me and you're not doing what I'm saying, and you go somewhere else and talk to other doctors, just go somewhere else. Don't come to me. You don't want that doctor. I'm sorry. And if you're one of the doctors that are a friend of mine that are doing that, I don't know. As a patient, you need to feel comfortable with your doctor, and you need to actually make sure that he's seen it for you. Because at the end of the day, you're not a statistic. Statistics are funny because it's 1% to 100% or 10%, but when you're that statistic, you're 100%. I don't know if you understand what I'm trying to say. What I'm trying to say is your wishes should be very important for your doctor.
So we're gonna merge into to Jan and Dr. Sartor's talk a little bit, because I know a couple of these guys that we're gonna look at some pictures of, and these are first it's theranostics, right? This is where this word comes from. It's essentially merging therapy and diagnostics together and just doing it all at once, right? You got to look and see what you're treating. Is that right?
And that's the beauty of nuclear medicine. You can have a biomarker that can be used to take a picture. You're just changing the biomarker. And then you exchange that isotope from a picture taken to a nuclear bomb. And I remember when I made this little video, it's funny because.
If it'll go. Whoops.
Is it going?
I don't know. Let's see if I can make it go.
Oh, you're gonna have to click on it. It's okay. Don't worry about it.
Okay.
But basically, you can send that micronuclear bomb to the actual metastasis, and you could see changes in these patients.
We're going to see a couple.
So this was one patient, very good friend with Mike, that my patients get together and talk and share their pictures, and I will tell you, like a friend of mine was saying, why you don't have more PSMA PET CTs from this guy? It's because his PSA is undetectable, and I don't want to do more PET CTs if he doesn't need it. However, you'll get one when the decision is triggered, but this is his 3 post-therapeutic SPECT CTs. You have a PET CT in the corner, PET CTs in the corners, and the post-treatment scans in the middle between the 3 treatments. The point is, patients respond really well, but not all patients are the same. And when I brought this patient the other day, a couple of years ago to the society meeting, he went to Novartis and he went to all these sites showing that, yeah, this worked for me. And when you are in a good regimen and you respond well, there is no better feeling for a physician to know that his patients are doing well.
Yeah. When it works, it really works, is the point, right? And so here's another one.
This patient told me that when he saw Mike last April, he made him work like 10 miles in DC, and he was with us going to every single of the offices that we went, pleading that you look at what you do for prostate cancer. We need the research support. We're not there yet. If you pull funding from basic research now, you're gonna see that affecting patients years from now.
We do a Hill Day every year. We go to Capitol Hill, and this year our mission was, with the new administration, was to try to convince Congress to maintain the research dollars that are out there and not cut certain dollars, or if they're going to cut dollars, that we really force them, or we're really strong about telling them, and this is patients, this is you guys, telling the congressman that, listen, if you're going to make cuts and you're going to rearrange money, keep it in these technologies that are making a change and keeping people alive, okay? We're just at the beginning of research, I think, in nuclear medicine and its applications in the world. And it's a crime if we start cutting back on the research at this point. I mean, we should be accelerating research in nuclear medicine right now, not subtracting it, okay?
I was very clear to tell to the offices I had the chance to speak to. I told them, look, prostate cancer is independent. It could happen to Republicans, Democrats, or anyone. So don't vote on anything else. Just put patients first. And
this is the guy that we walked around with. So that first picture that you saw in there, I mean, he was diagnosed very late stage. I mean, metastasis across his entire body. And in pain, he would tell you that he was feeling the bone pains. And like Dr. Almaguel just said, I made him walk 10 miles across Capitol Hill. And, we laughed about it all afternoon and had a cocktail at the end. And that's what this message is all about. It's preserving life and preserving the quality of life. And giving a guy more and more years. I mean, he was facing something that was going to take him out in a matter of months probably. And, through, your skill and skills of other physicians, we're still having a good time.
well,
Where's this headed? Where are we going?
we're going to areas where we have more precise interventions earlier. And
Do you think it'll be targeted by an individual's requirement for treatment?
I hope that we transition from precision medicine to precision health. So how do we find a problem before it is a problem? And I know that Mike is very passionate about early detection and about decisions to change paths and processes, but I will tell you, and being here with very in this very meeting, I will tell you that this is a combination of multiple people with multiple ideas pushing the field forward. I couldn't have done a lot of the things I did for this patient without pillars in the field like Dr. Sartor, right? Dr. Richard Baum, or those people that have changed, that have done things for patients and they have put their lives and their careers to serve others, right?
Okay.
But I'll tell you, we're not done yet. There's still a lot to do. About 600,000 patients die every year of cancer. We are not there. We still need a lot of help. And yes, we need to celebrate our victories with our individual patients at this time. But I can tell you this. We need all your support and we need your intervention with people you know to pass this forward and move this field forward.
So what inspires you? Why are we here? Why are you here?
I'm here because of my patients. There's no one can give me anything that surpasses what I feel when I see one of my patients do good. And the trust that they put in me, I'm actually, I will tell you that being a physician is a great privilege because you're able to give hope. Even when the things are not like we were just going through. There's some things that are thrown at you that are not fair. But at least you know that there's somebody that's going to help you, that's going to be with you through that. And I get really upset when somebody says, the patient failed this therapy. No, the patients don't fail anything. We fail. Our therapists fail. The patients progress on therapies. What I can tell you this is today, you and your doctor should work in a journey that journey ends in a relationship that you know that you have somebody that cares for you, and you know that there's somebody that when he doesn't know the answer, he's going to go and find out for you. You're going to consult with his friends to see what can be done for you. And I hope that's what we're trying to do here. And patients and friends like Mike make my life better because I can have my patient call him and talk to him about other things, right? It's always good to have a message from a patient, somebody that has walked the walk, because it's different from me. Even though I've been in those journeys, it's not the same. You need to hear it from your fellow patients, and you need to hear it from people that you know that are committed for you.
Questions?
Mike, yeah, do we have time for questions?
Yeah.
Anybody have a question? Raise your hand and I will bring you the microphone.
Now it's on, yeah. Anybody have any questions that you want to ask Dr. Almaguel or myself?
And this talk was about nuclear medicine imaging.
Yes.
I have a question.
Yes,
I know that we're talking about the PSMA PET scan. I know there's right now FDA cleared or approved 3 different kinds, but then there's reference to a SPECT scan. Is that something you use after treatment to monitor treatment because insurance would not pay for a PSMA PET scan unless your PSA was going up? Did I get that right?
In nuclear medicine, we're so privileged that therapy that you're getting, right? That when you switch from the micronuclear bomb to go destroy the cancer cells, that is beta radiation that is killing the cancer cells, but also has gamma radiation that can tell you exactly where the cancer cell which cancer cell is taking the medication. So you could see what your therapy is, and that's why we use a SPECT CT.
Thank
It
you.
could be done right after the therapy. So it's not a substitute for a PET CT, but it's a very good idea for you to know how are you responding.
As a patient, should I ask my doctor about a SPECT scan?
I would,
Okay,
if possible. I want
Yeah.
you to get it, yeah.
yeah. But it happens right after the PSMA PET? Is that what you're saying? Or
I mean, right after the PSMA radioligand therapy, the therapy.
right after the therapy?
therapy.
That's what I was, right, because at that point, insurance wouldn't pay for a PSMA PET if your PSA is going down.
Yeah, I think.
That's not how the label reads,
Well, you see,
correct?
we can go into the appropriate use criteria, and there is
Okay.
a somewhat appropriate to do a PSMA PET CT to assess progression or response, right?
Right.
So you can have a PET CT to see how you're responding. So it's not only for resources, but it's like that is free. It's a free imaging. You already have the radiation within you after therapy. You have up to a week to do the SPECT CT. So technically, I will love all my patients that have therapy to have a SPECT CT.
Okay, I'm just,
It's not easy, but yeah.
want to help patients know the questions to actually ask their doctor in the appointment, to really give it to them with some clarity, because it's hard. The information is overwhelming. So anybody else have a question?
One
I
in the
got
back.
two, hang on.
Yes, sir. Oh, wait, go ahead, Frank.
Hey, Frank Leskus, Blue Earth Diagnostics. Earlier today, Dr. Aiken talked about radiation exposure to patients, and of course, when we're talking about late-stage disease, I'm not sure it really matters at that phase, but if we're doing a SPECT CT following each application of Pluvicto plus a PSMA PET in the beginning and maybe a PSMA PET after dose 6, that could be 6, a bunch of different scans. Is that increasing the radiation exposure to patients that we need to be concerned about, or is it, okay?
In the SPECT CT, especially when I'm just doing a whole body scan, there's no extra radiation for the patient. He already had the radiation. He will lie there, and the machine will pick up the energy. There's no extra radiation to him. And there's a lot of useful information that could be used in the future. I mean, look, you saw the pictures from my patient. We have SPECT CT after every treatment, and that's not extra radiation for him. It's just he shared his radiation with us. So if I had to give him radiation after, then that would be different. But I think it's a good technology. It also can be used to measure dosimetry that could affect the way that I will do the next treatment in the ideal future. There are trials working on that. So the bottom line is, for a patient with advanced prostate cancer that is undergoing these treatments, information is good.
That's good. Mike?
Yeah, Mike Philbin, I'm a patient. So I've got a question surrounding if men have biochemical recurrence. At what level of PSA or range would you typically start being able to see something on a PSMA PET? At 0.2 nanograms per mil, at 0.5? Where typically might you see that?
That's a question that Dr. Sartor and I get often. We have new powerful scanners, but the rule of thumb is that 0.5, at 0.5, I have a 40% chance of seeing something. Dr. Sartor, can you answer to that, please?
No, it's a great question, and it kind of depends on when you ask and where you go. And so the conventional gallium-68 and F-18 imaging, Frank is exactly right. If you're in that kind of 0.2 to 0.5 range, it's only about 40%. But there are new techniques coming, and they're different ligands, different isotopes, copper-64. There's a clinical trial with copper-64 that looks pretty promising.
Oh, yes.
Yeah. And so, and that might change. There's also some interesting hardware, software solutions to this. I spent a little time down with Rod Hicks down in Melbourne, and with some of the newer scanners, which are very restricted in the U.S. today, the sensitivity can be dramatically enhanced. So when we talk about that 0.2 to 0.5 and quote the literature, it's a changing dynamic, and it could be a different answer tomorrow.
Absolutely right.
Thank
That's
you.
why I got, when you have a question that is complicated, you load the boat.
So we have a question from YouTube, I think. I'll come to you, Frank, just a second.
Yes, thank you. A question online that is asking, sorry, scrolled down on me. Oh, they retracted their question. Sorry.
They retracted their question.
Yes, message
Okay.
retracted.
We're
so-
friendly, they can ask questions. If we don't know, we'll figure it out together.
So, sorry about that.
Yes,
Any
sir.
other questions? Please wait for the mic so that the people online will be able to hear as well.
Yeah, just a
Thank
second.
you.
Yes, these new technologies are processes where you actually target the very specific cancer cell. You know, with prostate cancer, in the days of old when I had my radiation treatment done, basically it killed the prostate. With these new targeting things where they go in and hit the actual cancer cell, will that prostate then be viable, live, whatever you want to call it, after the treatment and the cancer cells are gone?
You know, that's an interesting question because I think today prostate is still the only gland that is treated from a whole gland perspective. Like every other gland in your body with cancer, they take out like a piece of it or a portion of it, right? So we just haven't probably complained long enough yet or loud enough yet. I don't know. Do you think we're going to get to a point where we can actually viably treat portions of a prostate?
I think I might have to phone a friend here. So I'll tell you something. I tell you experience.
Which one do you want?
Put the one where you saw, where there is like a ball, all the way to the beginning.
Oh.
Keep going. And I'm gonna tell you something about that.
This one or this
the other
one?
one, the one.
Yeah.
That patient. He was a doctor. I said, look, I just want this dot to be treated. I don't care if you have to come back tomorrow to treat the other one, but you just treated that one. I will tell you, we do things based on evidence, based on clinical trials that we have proven outcomes. I don't know about the future, right? Now we're merging with all this imaging, right? We're doing PSMA guided radiation therapy, external beam radiation therapy. So the future is exciting, but also we have the fear of change. There are many changes coming, right? That we are in a field that today they're going to present things here that we didn't know yesterday, and it might change the way we do things tomorrow. I don't know the answer about this, but the urologists are doing less prostatectomies and more focal therapies. In the future, you might be able to have a focal therapy to your prostate cancer that might, yes, it might leave other areas where the cancer can grow and cause problems in the future, but maybe it'll buy you some time without more intervention. But I only tell you that research we will continue to find ways to increase the quality of life of our patients. So as of today, yes, when you have prostate radiation, classic is not really the whole prostate. Now people are saying PSMA ligand therapy, that you do it when there are patients that have diagnosed like the patient you saw there with hundreds of metastases. They don't get a prostatectomy or radiation to the active prostate. But I'll tell you in the future there'll be other things that we could do. But you have to stay engaged and stay positive because there are great things happening in our field because of advancing technology and because of physicians that are pushing the field forward.
So anything's possible, but it's going to be really difficult if they keep cutting research funding.
Yeah, right.
Is that fair?
That's fair. That's
Thank
fair.
you.
I just want
Thank
to be
you.
happy.
So write your congressman. Tell him to keep the funding in line.
Right.
Okay? So we're going to merge now to our next speaker.